Very good. So just to use the same framework that that Christine was using, SCYLLA is going to be focusing on population level effect estimation. So that's looking at the causal effects of medicines in this case. The reasons we want to do this study are many, but the main one is that the treatments for COVID-19 have evolved very rapidly in the last year and are now divided into groups, including antiviral, antithrombotics, immune-based therapies, antibiotics, and concomitant treatments. And there is an increasing number of trials reporting findings on these and even living meta-analysis of those randomized controlled trials. But to date, none of those are comparing one treatment to another. They're all comparing either to placebo or, confusingly enough, I would say, to standard care or routine care. But we don't know. We're going to be left without knowing whether all corticosteroids are equally safe or effective, or anticoagulants are better or worse than antithrombotics, and the same will be true for antivirals and antibiotics or any other treatments. So again, to cover the methods of this study, the full protocol is available and has been registered in this link here. And of course, we'll post the slides later so you can go through it. We are looking at new user cohorts, and we are looking at different settings because we understand that that is a natural history of this disease called COVID. We have this outpatient setting where we look at people who initiate treatment in the outpatient or before hospital admission when they get diagnosed with COVID-19. In that particular sub-study, we'll be including admission to hospital as a kind of outcome of interest. Then we do have also the inpatient setting where we look at patients who received treatment, who started a treatment on the day of admission, similar to what many of the large trials like Recovery are doing, and also to people who start treatment during the hospital admission, but before ICU care. We are using a new user active comparator Cohort Design, which is recognized as the best or the gold standard in regulatory sciences and pharmacoepidemiology. We will use large-scale propensity scores to minimize issues to do with observed confounding, so with any variables that are recorded in our data, and our and I'm going to shout out and thank Martijn and Mark and all the team that have been working for ages on the OHDSI library. We also have the tool of negative control outcomes and empirical calibration. We are using 4 diagnostics that we are looking at before making any inference from the data. The first one is whether we have power or enough sample size for a drug outcome setting analysis. We will then look at propensity score models and overlap between those. We then look at covariate imbalance in the observed variables after propensity score matching or stratification, and finally systematic error as measured using our negative control outcomes. Now, we had some predictable challenges that only became predictable once we realized of them, and these included the issue with instrumental variables sneaking into our propensity score models. So propensity score, as you all know, is the probability that someone receives a given treatment based on his or her individual characteristics, and there are sometimes variables in the health claims or EMR data, like administration of an injection, for instance, that can be very highly correlated to the treatment of interest. We tackled this and we found a solution that I think deserves further investigation and deserves probably becoming something that we implement in the future. And it was looking at the correlation between the concepts and these TOC cohorts or treatments, and then we excluded those that had a very high correlation coefficient, and that really worked out and resolved the problem. This is, by the way, not a problem that is unique to SCYLLA. It happens in many PLE studies that we perform in the community and even out of the OHDSI community, of course. The other issue that we haven't so far managed to resolve or not entirely is that there is a crazy amount of different medicines being used for COVID, many times concomitantly without too much evidence base, as you all know, and it's relatively rare to find clean new user cohort for any given medicine. We have ended up with mostly inpatient treatments, passing diagnostics, and only large cohort and large databases are making it into the final analysis. So I think the situation with COVID is such that it is very difficult to do this kind of new user, clean, active comparator cohort designs. I'll show you now some results that I consider are final and there for the community to share and to explore. And this is the patient-level drug user characterization. This is the bit where we basically identified the potential participants for SCYLLA and then looked at their baseline characteristics at the index date and up to 30 days after the initiation of a given treatment. Anthony Sena and the team have created this wonderful shiny app that you can explore, where you can look at cohort count for a given treatment in a given setting. You can look at characteristics of a cohort. You can even compare cohort characteristics, and I'll show you just a couple of examples of this. So this is an example of uses of dexamethasone uses of dexamethasone in an inpatient setting in a number of different data sources, and you can see here the demographics. Just by changing the tab on domain, you will be able to explore other features like treatments, outcomes, and so on. This is now the compare cohort characterization, which I think is a beautiful visualization of what confounding looks like in pharmacoepidemiology. And here you can see how uses of hydroxychloroquine are different compared to uses of hydroxychloroquine and azithromycin, which is another common combination of treatments that was given mostly in the first quarter of 2020. This is a detailed view of how you can see demographics or conditions. This is a view of how you can, gosh, something went wrong with that, of how you can visualize hospital admissions and ICU care in cohorts of azithromycin users, hydroxychloroquine, and a combination of hydroxychloroquine and azithromycin in different data sources. This is, again, a visualization of antivirals in Premier, and this is, again, a visualization of immune therapies in two different cohorts. And now in HM and Optomy HR, you can see how you see exactly the same trend with dexamethasone users being having a slightly higher prevalence of almost any confounder you can think of compared to prednisolone users, both in HM, which is a hospital dataset from Spain, and Optomy HR in the right. And finally, the bit that's been harder, which is doing the estimation part of the study. I'm going to just show you some preliminary findings from the comparison of heparin and aspirin. We really don't know whether anticoagulation is worth it, beneficial and not too risky for patients with COVID-19. We do know from Charybdis that anticoagulants and antithrombotics, and this is heparin and aspirin here in the screen, are heavily used. So about 30 to 40% people admitted with COVID-19 get heparin, and about 20% to 30% get aspirin. And this hasn't really changed over time. So in the data sets where we still have data until the second or third or fourth quarters of the last year, we can see how this is relatively stable. So the evidence, there is some evidence. There is a preprint of a large multi-platform pragmatic RCT suggesting that heparin can reduce morbidity and mortality in patients who are in the COVID wards, but not in those who are already in ICU. And there is an analysis of VA published in the BMJ last week showing a 30% reduction in mortality. Now, the question is, would platelet aggregation or antithrombotic therapy be safer, and would it already do the trick in terms of reducing events for these people with COVID-19? So some findings now. This is the comparison of heparin and aspirin. These are the diagnostics from IQVIA Hospital CTM database. You can see how there is some propensity score overlap, and there is after propensity score matching. Now I'm looking at the bottom half of the screen. Good observable balance or no imbalance after PS matching. We then look at the effectiveness outcomes, and you can see how, as expected, heparin leads to a lower, about 25–30% lower risk of cardiovascular events. No impact in our data on ARDS or intensive services. There is a signal potentially for an increased risk of intensive services in heparin users, and we do observe an increased risk of death, and as a result, probably a reduced risk of discharge from hospital. In terms of safety, we don't see any major events. Maybe there is a signal for hemorrhagic stroke, which could be expected, and there is an unexpected but to be confirmed signal of acute kidney injury. And then the most interesting findings we do see when we look at what one could call expected outcomes, that heparin indeed reduces the risk of ischemic stroke and acute MI compared to aspirin, but we do see quite a massive increase in the risk of VTE. We then look at negative control outcomes, and unfortunately, and this is why I'm calling all these data preliminary so far, we don't have sufficient power to do a really good assessment of confounding based on negative control outcomes. Now, this is just to show you what a good assessment of negative control outcomes would look like with a much smaller standard error and many more outcomes in the analysis. So we are looking into what should go next. There are at least 4 options that we are looking into. One is maybe seeing whether we can fix or whether there is any previous evidence that there is index date misclassification with VTE events, because it could be that surprising effect is indeed due to misclassification of the index date of venous thromboembolism. We could look for additional or alternative negative control outcomes. We are aware that the usual negative control outcomes don't seem to work too well in the inpatient kind of acute care settings. And we could, of course, run the SCYLLA estimation package in additional databases and gain power and potentially do better at the negative control outcomes. And if you want to participate and have some data to contribute, by all means, email me and we will be delighted to liaise with you. And of course, we could also wait for more data. When databases are updated, we will have larger numbers of participants in those same databases. I am not going to have time to submit this to a vote now in the community, but I am just going to mention that my choice would be probably option 5 in there. And with that, I want to thank everyone who's been contributing to this, especially all our colleagues in the OHDSI community, and Martijn and Mark, who have put a lot of time into this project. Thank you.